You're listening to Simply Put, a podcast from FHN Financial. I'm your host, Will Compernell. Rural hospitals in the U.S. receive public support to help ensure that low-density populations have access to adequate healthcare coverage that would not otherwise be provided by the private sector. This year's One Big Beautiful Bill Act pairs federal spending cuts for these rural hospitals with new incentives designed to increase efficiency and minimize wasteful spending. $50 billion for a new rural hospital fund aims to help ease the transition, but state governments may still have to decide whether to fill any funding shortfalls. On today's episode, we talk with Steve Parente, a professor in the Department of Finance at the University of Minnesota, about the defining characteristics of rural hospitals, how the OBBBA changes their financial incentives, and how states may choose to respond. Stay tuned. Coming up soon, our interview with Steve Parente, but first, a quick market update. President Trump signed a bill Wednesday night to end the longest federal government shutdown in history. The shutdown is expected to harm fourth quarter economic growth with a rebound in the first quarter. As of this recording, the BLS has yet to announce the publication schedule for the data that were originally scheduled to be released during the shutdown. The private sector data over the last 2 weeks provided mixed signals for investors who have been almost entirely without government data since October 1st. The ISM services and ADP for October came in somewhat stronger than expected, causing a modest Treasury market sell-off on November 5th. The next day, the rise in yields reversed after data from Challenger and Revelio showed a spike in layoffs and negative monthly job growth, respectively. Ever since the October FOMC meeting, Treasuries have been trading in relatively narrow ranges, with 10-year yields moving between 4.05% and 4.15%, and 2-year yields trading between 3.53% and 3.63%. Bond investors are reluctant to establish new anchors, while a backlog of unpublished government data could soon redefine the outlooks for the economy and rates. Treasury's quarterly refunding announcement on November 5th went mostly as expected. Nominal coupon auction sizes will be unchanged for the next 3 months, and Treasury expects this to be the case for the next several quarters. There was one hawkish sentence added into the statement this time, however. Treasury has started to, quote, preliminarily consider future increases to nominal coupon and FRN auction sizes, end quote. In other words, they've started thinking about how to eventually increase the issuance of nominal coupon securities. The Supreme Court heard oral arguments last week regarding the legality of President Trump using emergency powers to implement most of this year's new tariffs. A majority of the justices appeared skeptical with their questioning, but that does not always predict how they will end up voting. The court is expected to rule by the end of this year, and most analysts predict the president will pursue other avenues to enact these tariffs if his previous route is deemed unlawful. That's all for the market update this time. Now, our interview with Steve Parente. Our guest today is Steve Parente, professor in the Department of Finance at the University of Minnesota. Steve, thanks for coming on the podcast.
Happy to be here.
Our topic today is rural hospitals in the U.S., how recent legislation will change their financing, and how different states could respond. Now, Steve, I want to start by setting the scene for why we are talking about rural hospitals instead of, all hospitals in the U.S. Let me know if I'm missing anything here, but my understanding is that there are areas of the country with low enough population density that the private sector would not find it worthwhile to provide sufficient healthcare coverage. So, for many of the same reasons, there aren't big airports near everybody. Hospitals require a lot of infrastructure and high-paid staff members. So if there aren't enough customers, so to speak, nearby, the hospitals won't get built. But at some point, we as a country decided to fill that gap so that people wouldn't have to drive 8 hours to see the nearest doctor. Is this about right?
It's about right, but I mean, the thing to keep in mind too is that a lot of these hospitals and infrastructure goes back a number of years too, where like some of these rural communities were bigger back in the day, and they could support, if you will, a less advanced healthcare delivery system where a family doctor and or a nurse that may or may not have been that person's spouse could like basically do a lot of stuff before you needed to have a rural hospital.
I see. So let's talk a bit more about the operations of these hospitals. Are they publicly owned and operated, or do they get financial assistance from the public sector? What exactly separates them from hospitals in areas with higher population density?
Yeah, that's a great question. So, obviously the biggest thing, and you alluded to it, is that they're obviously smaller. They don't have necessarily all the economies of scale and scope. Their financing does vary. You're not going to see a lot of small rural for-profit hospitals, though interestingly, private equity and some for-profits have purchased them when they become distressed and or close them, consolidate them, put different resources in play. But for the most part, the dominant governance structure for hospitals, rural hospitals included, is nonprofit status. And that also obliges them to do a certain amount of work for free as well, as sort of with Medicare payments the way they want to get paid. The real challenge with these institutions is that it's very expensive to keep a staffed bed available all the time for all situations. And, healthcare costs and labor costs have gone up quite a bit. And the other challenge you run into as well is that, you really need to have a lot of technical expertise to do medical procedures well. And if you're only doing a handful of them, that actually puts the rural hospitals at a disadvantage. People don't necessarily want to come in there as much. But they're a unique space. Now, one thing to keep in mind is that their financing has changed over a period of time. The Medicare program is one of the probably funds about half of hospitals' revenues in general for people age 65 and otherwise. And the Medicare program, early mid-1980s on, came up with a different way of reimbursing the hospitals. That hurt the rural hospitals quite a bit. And so in the 1990s, late 1990s, they reversed course and gave the hospitals a relief, if you will, from that system, which you might say, that's great, problem solved. The issue was that it's still the case that populations are emptying from rural areas, moving to more urban areas. And the financing of those hospitals actually got complicated, where larger hospitals started buying them to become feeders and even taking some of their beds away to the more urban centers, just because the rates were better. There's always a financial shell game that goes on with these hospitals. You have to look at that picture too, and not just hold the hospitals in isolation in their space.
So you alluded to this a little bit, but just to get a little bit more detail, the financial assistance from the federal government for these hospitals, is it coming from the supply side, so to speak, where they're getting grants from the government to just exist and keep those hospital beds and certain procedures available, even if no one is particularly using them frequently? Or is a lot of it coming from the demand side, which is that Medicaid, Medicare, other government assistance is giving help to these patients to be able to afford more healthcare coverage than they would without the federal assistance?
It's actually a combination of both. Inside the U.S., the Federal Department of Health and Human Services, there's a part called HRSA, Health Resources Services Administration. They have a rural health policy office. They do provide additional grants for rural health policy training, rural graduate training, program assistance in those spaces. Keep in mind that, like, we're just talking regular rural hospitals, because we also have the IHS, the Indian Health Service, that runs on reservations across the whole U.S. that's separate from that, and that's federally funded too. And then on the demand side, you're right. As I mentioned, the Medicare program really funds what they consider to be critical access hospitals, which are in rural areas, but they can also be in urban centers, and they fund them more generously so that they can stay into operation. Now, the Medicaid programs that are designed for the poor, they typically don't do that much more for the rural hospitals, because they are budget constrained by the states and or the federal government resources that are coming to sort of match the state's funding. But for the most part, there is definitely a demand and supply side aspect of it. The challenge is, these are all federal and state funds, which are in competition with other factors at the same time.
When we say rural hospitals, how many hospitals across the country are we talking about, at least as a share of all the hospitals in the country? Is it really a strict dividing line of what constitutes a rural hospital, or is it just a really, you know it when you see it, and at some point population density is low enough where we say, this is a rural hospital?
It definitely is tied to population density. Part of it is population density and then really the bed size of the hospital. So take, for example, the Mayo Clinic in Rochester, Minnesota. If you've ever been to Rochester, Minnesota, you'll see a lot of farms around it for about 80 to 90 miles before you get to Rochester, Minnesota. And yet it is a major medical center, even though it's kind of located in a rural area, whereas, say, another 300 miles and find a similarly sized urban center, I don't find a Mayo Clinic, right? So part of it is the number of hospital beds that are around that area. And typically the rule of thumb is that when you're talking about 30 beds or less, it's definitely a more vulnerable institution in terms of just keeping the staff and how it's operating. And then the other thing you got to worry about, the primary labor force of any hospital is nurses, more so than physicians. And so you have to make sure that you can pay them adequately, or you're going to run into issues in terms of staffing shortages. And so one of the big challenges with rural hospitals is that you got to figure out, is that rural area, whether it be ex-urban truly or rural is declining in terms of population growth and it's just aging in place, because those are typically the hospitals that are the most vulnerable. There's a lot of small towns in America where actually my family that are from some of these places too, where like their largest export good is their people. They're moving to the cities, they're getting out. There's not a lot of folks coming back. And so those institutions usually become the most vulnerable and get to a certain point where they either consolidate or they close because they just can't maintain an adequate level of staffing to operate.
Yeah, and I think that's an interesting point that maybe is sometimes missed is no matter what the amount of federal or state funding, you can still have a shortage of the necessary staff. I believe it was West Virginia that had these intentions for universal childcare at some point. Well, you also need enough qualified people in these very rural areas to work as childcare providers. And so on that point, it's obviously very important to think about how these rural hospitals provide medical coverage to these people in rural areas, but how big of an employer are they, right? If these hospitals are sensitive to lapses in funding, does that also mean that, the biggest job provider in a few counties nearby is suddenly lost?
Right. Unfortunately, that leads to a sort of a spiral of that community. I've traveled through the U.S. quite a bit. I've been through all the lower 48 states. I mean, there are states where, like I'll just be specific. You go to West Texas, and you'll see just whole towns are just abandoned. And a lot of that's just the boom and bust cycle of like the oil regions of what's occurred there. Whereas if you go more, say, upstate New York, rural Pennsylvania, West Virginia, as you mentioned, rural Virginia, towns that were more vibrant that are just getting smaller and smaller and smaller. But to your point, like one of the last major employers is that healthcare community because a lot of that population has aged in place. And it does put them in a vulnerable situation because, good talent goes where good talent is. There could be the greatest doctor that wants to stay there forever, but more advanced care needs more additional treatments. There are things, for example, where, you go back 30 years, someone has a heart attack, it's considered a death sentence. Now it's considered a chronic heart failure journey where you're going to get, a cath lab that's going to come in there. They're going to put a stent in there. And so those sorts of technologies that we consider minimally invasive, which sounds like it's a Band-Aid. And what's true is that there's a Band-Aid incision, but you're literally having someone snake a wire through a whole artery and vein system and sort of put in a little metal stent, pull it out, and do it at scale. And that's not easily done in rural hospitals that aren't really scaled up for that. There is a concern that's valid that, like, if the hospital gets too small to have an adequate level of quality, then you have to think about more carefully, like, if you do close it, what do you do to make sure people still get access to care?
Yeah, I can see, as you said, a negative spiral where if there isn't enough staff in the area, then the population goes down, and so there's even less demand for these hospitals. And who wants to live, in an area where there's not healthcare coverage? And so I can see how that can be really a negative feedback loop. I want to go back though to a previous question, which is what share of the population is served by these rural hospitals? Are we talking about a small percentage of the population, or how significant is it?
It's non-trivial. I mean, if you look at, all in, there's probably, in terms of what would be considered to be critical access hospitals that are rural, out of like 3,000, what we'd call 3,000 general hospitals, about 1,000. And so it's not necessarily a small number. And some of those institutions are quite small in terms of where they're operating. Now, many of them have referral networks to larger institutions, and so they can maintain other aspects of it. It does depend on the state and the culture of that state in terms of how well they integrate or don't integrate in terms of the systems that are there. There's for-profit hospitals that have come in So, for example, there was a lot of hospital closures when hospitals just got old, and there was a quality concern in the 1990s. And sort of major corporation out of Nashville, Hospital Corporation of America, started just buying up older rural hospitals and either making them bigger and cleaner and integrating them, or closing them down and making some really hard decisions, which for many communities were hard, but at the same time, they didn't have the capital to do anything with that. Flash forward now 30 years, really, and private equity is coming into these institutions as well, which are kind of like, well, why would they do that? But there are incentives for them to, again, try the same sort of consolidation play. The challenge is that the money to be got in those places is harder to get. It does create a real financial challenge to kind of have that viability. It serves a large part of the continental U.S. There's really only about 4 or 5 major urban corridors in the U.S. The rest is largely served by these rural hospitals. I mean, you got the Acela corridor, you have Florida, you got the Midwest, and you got the Pacific, and then there's a cluster in Texas. Other than that, it gets rural pretty quickly.
Digging more into that trend over the last 20 or so years, when these hospitals have closed or struggled, what can we say about the changes that have occurred? So is there less quality healthcare coverage? Are people driving further to get care? Before the One Big Beautiful Bill Act passed, what sort of environment were these rural hospitals facing as far as their trends?
So one of the things in the One Big Beautiful Bill of having that additional money there is to put an emphasis on telemedicine, to connect the hospitals better, to like find ways that they can be bolstered using modern technologies, linking medical records, which was actually successfully deployed. There's one thing Hospital Corporation of America did is they had a huge, massive electronic medical records deployment. So at the very least, for a patient that was older, you knew what tests they had previously, whether they needed to have it or not, what are their complications, which makes a big difference. If someone presents in an emergency room situation, you really need to know a little bit better what's going on. And granted, in a rural community, everybody may know each other and they kind of know, but they may not know the exact diagnostic tests, the ejection fractions of their last heart attack. So what happened before a Big Beautiful Bill was that, and granted, this is still waiting for this to deploy, was that, a lot of these hospitals were, struggling. They have financial concerns. You have year-over-year increases. COVID did not help them, right? Because they suddenly had to put out all this additional money that they didn't have on PPE, on all other elements of what they were doing. I was actually part of Trump 1 administration to try to hot deck money into those institutions. But at the end of the day, like we did do a big deployment, or like $5 billion over the course of one day to rural hospitals. I know fairly well where they're located. But that doesn't necessarily solve the bigger issues that they were facing at the time. And the reality is that, as we talked about before, when a community is in decline, short of like saying like, hey, here's like 5,000 more people into your community, make sure everything works, there's not much you can really do in that space. And again, where the challenges run in is that every one of these hospitals has some sort of a quality accreditation system that goes along with it. And so if that hospital is doing poorly, keep in mind, there's still a private health insurance system that's there. There's pressure from the private health insurers to say, like, that hospital's not doing very well. Maybe we don't want to make it part of their network anymore, or we want to redirect because we know that their readmission rate is not good. And that could be because of a staffing issue. They just can't get the people. There's more likely that there's an infection post-operatively that occurs because they couldn't get to them fast enough. So what One Big Beautiful Bill tries to do is say, like, what are modern things that we can do to make the system work better, have better information, coordinate more, and probably even think about consolidating better. It's terrible to drive a long time if you are distressed. There are things along the way where you potentially can do a telemedicine visit and try to triage better. Do you really need to drive to the hospital now? Is it possible that there is a visiting nurse service van that's running around that could address something before it becomes a problem? Even things like appendicitis, if they're actually treated essentially by an advanced nurse practitioner coming to your home, may prevent an acute hospitalization if you get ahead of that type of thing. So it's those sorts of modern technologies where you don't have to rely so much on the old school bricks and mortar institution that could be very helpful.
The intention then is that there is a maintained public support for these areas. We're not throwing money at institutions that really aren't doing things efficiently, aren't doing things effectively. But of course, there is still potential issues with support lapsing and then affected areas go uncovered. And so tell us more about the Rural Hospital Fund that I believe was added really in a last minute part of the legislation. What exactly is the Rural Hospital Fund doing?
What I know from talking informally to some folks about where the needs are and where the technologies are, it's designed to essentially provide a resource that's more than a year or two, like over a period of, could be a decade really, to essentially transition some of those institutions to sort of handle the needs of the future. Because, I mean, part of the issue is going to be, do those areas where there's rural hospitals, are they growing or not? Back to the critical shortage issue, and giving them some runway rather than an emergency situation to pull everything out, and then figuring out what are the technology vehicles we can deal with to kind of make things more rational in terms of where things are and keep eyes on them in a more coordinated way. It's a little bit back to the world of, the U.S. has sort of experimented from time to time with rural health planning, where you actually do try to have the federal government play kind of a role in that space. HHS has a history of doing that. They know where these institutions are. They have a lot of federal data to see where things are moving in them. And I think part of it is to utilize those resources to figure out what's a better strategy. And the U.S. also has experience in this and trying to do things better with other laboratories. So the Veterans Administration, for example, makes a contract with every vet that says, like, we will serve your care after you're done with your tour of duty till you die. But to do that effectively, the VA actually is probably the closest analog to the U.S. having a British National Healthcare Service, where there's like 2 or 3 more than that, major tertiary healthcare centers that serve multiple states, and then rural community hospitals, and then basically community clinics. All of them link in a way to kind of integrate that person's care in a very deliberate way. And so the thought is, like, the Rural Hospital Fund will provide that mechanism to keep these institutions in operation, and then also look for other opportunities too. Like, they still can make money serving different populations and sort of figure out a way to do that in a way that's more efficient.
Ideally, the Rural Hospital Fund and these new incentives to increase productivity would make it so that coverage stays the same, improves, that the funding cuts from the One Big Beautiful Bill Act don't result in any negative effects, right? Ideally, there are never any negative effects from new legislation. But the funding that is provided for the Rural Hospital Fund, how much does it work towards filling that funding shortfall? Is it, a drop in the bucket, or is it really going to ease the transition?
$50 billion goes a long way. Like, when we had to more or less recapitalize the rural health centers during COVID, and they were really bad shape, I mean, we spent a fraction of that $50 billion. So this money can go beyond 1 year. To your point, I mean, there's still a lot of active revenue that's coming in from the state Medicaid programs, from the Medicare program, from private insurers that are in place. What this is trying to do, because, I mean, there's other cuts that have been made, right? So one of the big concerns with One Big Beautiful Bill, where the cuts are coming from, is folks that are basically enrolled in sort of Medicaid and a private insurer when they really should be enrolled in just one. And, like, pick which one you're going to do, but the government should not pay for both, right? And so that's going to lead to a cut, because we've really not really actively managed that and sort of said, really, it's one or the other. And we know it. It's just that I think the most recent administration really put an emphasis on, let's try to get as many people as we possibly get covered as possible. And granted, during COVID, that makes sense, but after COVID makes less sense. There's also the restrictions on, and this could be a major concern too, and I'm not quite sure how this works out, where you have a lot of migrant communities in those rural areas, right? And so if you're essentially trying to serve the migrant population that's there, that essentially are not U.S. citizens coming in as migrants under legal visas, to what extent is that population going to be harmed if you pull out state monies that were going to Medicaid that maybe help them, so they should not have been helped that way, and then the Rural Hospital Fund helps fill in that gap? It's a big empirical question to know whether or not that becomes a concern or not. The one thing that's also lost too is that every hospital that accepts Medicare, and granted, every rural hospital accepts Medicare, has to take an emergency patient no matter what. And granted, that's going to cost them money. That's where the rural fund actually is helpful to make sure they don't go bankrupt. But in terms of an access issue where someone's like, people are going to, you've heard in the media, people are going to die because of the one big beautiful bill because they're going to be denied care at the hospital. Legally, they can't do that.
Right.
If a hospital legally denies someone care in a rural area and they're accepting any sort of federal funds, they are going to be shut down because they violated federal law.
How much fiscal space do you think states have to make up the funding shortfall? Are they operating from a position of flexibility where, okay, the federal government has cut off some of this funding, but states will fill in the gaps? Or do they have no choice but to kind of let that funding lapse? Because, and maybe I'm really overgeneralizing here, but when I think of the most rural areas in the U.S., a lot of them are in states with lower than average incomes that might not have as much revenue as, the higher income states that are also benefits of higher population density.
Yeah, I mean, it's true. One big factor here is Medicaid expansion that occurred in the Affordable Care Act. I mean, that has provided states with more revenue for their hospital sector. It's just a given. And you have two major states that have significant rural populations, Texas more so than Florida, that have not expanded. But yet they are operating, right? They are finding a way to keep as best they can those institutions in operation. And part of it is going to be, where do those dollars come from? I mean, the interesting thing is that there's a lot of private equity money in Texas, even though they have not expanded Medicaid, and yet they're finding a way to kind of make some of those things work. So it is true that like urban corridors have a bigger tax base, but at the same time, there is a long history of some of the smaller states that don't have the urban population. They have been finding ways to manage in different ways. And granted, you go out to real Mountain West, I mean, you have, vast areas that have no coverage whatsoever, where people just know that. They weren't forced to migrate there. They are living there because they want to live there, and either it works for them or it doesn't work for them as they move forward. The hope is that in an emergency situation, they are able to get the care that they need. But keep in mind that, the most extreme sense, helicopter provided care is super expensive. So it does require, it's incumbent upon the citizens that are there to just sort of think out loud, to think about, how do I really want to get treated as I get older?
So I want to end with perhaps the most important question, which is your prediction on how these changes in legislation and fiscal support from the federal government will impact healthcare coverage and state government budgets. Do you think the incentives are positive enough to make up for those funding shortfalls? Are we going to see really deteriorating coverage in a lot of these areas? How do you see the next 5 to 10 years playing out for healthcare coverage in rural areas and state government budgets?
Great question. When you think about the overlap of coverage, the money that we were spending that really benefited nobody other than maybe an insurance company got extra money for people that weren't even using the service, that helps nobody, right? So to the extent the One Big Beautiful Bill helps redirect those funds to do something useful, great. The other thing the One Big Beautiful Bill does in the insurance market, the private insurance market, is it allows people to buy insurance that's catastrophic above the age of 30 into age 64. On the one hand, you could say well, that insurance isn't so great. There's a high deductible that's associated with it. So, but I'm an economist, so we focus on the dismal science, basically part of it. But what I can tell you also as a insurance professor is that having some insurance versus no insurance is just statistically better than anything. Because at the very least, you get to negotiate, even if you're paying cash, right? Before you meet your deductible, you're paying the negotiated rate that insurer made ahead of time, and you get primary care for free. I mean, that's part of the rules in the ACA. And your premiums might be literally half of what they were previously. Here's what I'm tracking from the One Big Beautiful Bill to see whether or not actually access to insurance gets better, gives people at least more protection than they have as opposed to being uninsured. And then let's see how the rural hospital and the other programs play out. There's a lot more emphasis now on really using more advanced health information technology to link people's records. A lot of the biggest restrictions are people are concerned about privacy. But one of the things that could occur from the Rural Health Fund is to say, look, we understand that you may, hospital A, be concerned about records moving with hospital B, but here, you don't have the money to complain about that anymore. We need to actually integrate things better. And if there was a lesson learned from the VA, it was seeing that by having everybody be together in one system, you could actually really economize on the records to see what's there. My wife used to work for the VA. She had lots of patients that were coming for 400, 500 miles away, but she could know from the community health center records in that location what was going on before they showed up and was much able to take care of that. That doesn't typically exist in the regular private rural health market, let alone the private urban market. And I think that could be a real opportunity. I know some of the leadership at HHS that are thinking about this, and that's definitely a top of mind thing as they're deploying this as well.
Steve Parente, thanks for coming on the podcast.
Happy to do it. Thanks for the opportunity.
That was Steve Parente, professor in the finance department at the University of Minnesota. I think Steve brings up a really underappreciated point about changes to rural hospital funding caused by the One Big Beautiful Bill Act. Some of the lower dollar amount explicitly measured in the law reflects getting rid of duplicate payments, while some is from changes that incentivize less costly medical care services. Of course, only time will tell how these improvements fare compared to the lower federal assistance, the amount states will increase spending, and how the Rural Hospital Fund smooths the transition period. Rural hospitals were struggling even before the OBBBA was passed, so medical coverage could continue to decline for rural populations no matter the new efficiencies. Over the coming weeks, the BLS will gradually release the data reports that were delayed by the government shutdown. As of our recording, they have not yet posted a publication calendar, though we expect one soon. The Fed will release the minutes from his last meeting on November 19th. There were 2 formal dissents, but public commentary from Fed officials suggests support for an October cut was weak within the hawks who are worried about inflation. The Fed will also release its latest beige book the day before Thanksgiving. At the October press conference, Chair Powell said private sector data and anecdotal evidence would be enough for the Fed to identify any economic turning points, even without official government data. Whether or not he is correct, the Beige Book will receive even more attention than usual since it surveyed the Fed's 12 districts during the government shutdown. Trading volumes should be lower during the week of Thanksgiving, though there could be some volatility based on how the delayed government data releases turn out. The Fed's pre-meeting communications blackout will begin the day after Thanksgiving. That's all for today's episode. Thanks again for listening. I'm Will Compernell, macro strategist with FHN Financial. This episode was edited by Bill Stanfield. Don't forget to like and subscribe to Simply Put wherever you get your podcasts. Email simplyput@fhnfinancial.com with any questions or comments. This podcast is presented for informational purposes only and is not intended as an offer or solicitation with respect to the purchase or sale of any security. Views expressed herein accurately reflect the speaker's personal views about the data, news, trends, events, etc. discussed herein or any subject securities or issuers. No part of their compensation was, is, or will be, directly or indirectly, related to any specific recommendations or views expressed. FHN Financial, through First Horizon Bank or its affiliates, offers investment products and services. Investment products are not FDIC insured, have no bank guarantee, and may lose value.